my slides. Here are my disclosures right here. See here, and then here's an outline of kind of where we're going to be going today. So I'm going to be going through one challenging case example, and then we're really going to be focusing the majority of the talk on the treatment advances in pericardial disease with interleukin-1 and clinical applications, as well as going through a few of the current knowledge gaps related to the management of pericardial disease. And I'm going to start out with a case. This is one of my patients I've been taking care of for a couple of years. She's a 39-year-old female with lupus with refractory recurrent pericarditis. Here's her lupus history here. She had a quite prolonged course. It started in 2010 when she was in her early 20s at that point. In 2016, 6 years later, she had her first episode of pericarditis. She at that point had a kind of like a lupus RA kind of spectrum phenotype. She first trialed azathioprine. She went on abatacept, and then she went to belimumab. Belimumab, for those that are not rheumatologists on this audience, targets the B cell pathway. And then she started colchicine as well for the treatment of pericarditis, and she developed a rash. Unclear if related, but she was not going to take it anymore. And then in 2019, she added IVIG to Benlysta, and then this is when I began to see her in 2020. So just to pause here, I just want to remind everyone that acute pericarditis is actually a frequent manifestation of pericardial involvement in lupus patients, and it's a very common cause of chest pain. It's actually one of the more common causes, and this is something I actually see frequently in my clinic of my lupus patients. It's actually pericardial disease. And so when she established with me at that point, we had obtained a cardiac MRI. And here, my talk will not be as imaging focused today, but I wanted to just go through some of the highlights of her cardiac MRI. She had marked pericardial thickening measuring up to 9 centimeters with LGE enhancement. This was all features consistent with pericarditis. I'll go through that in a little bit later in the talk. She had no features of pericardial constriction. Her LV was mildly dilated. Otherwise, there was normal LV and RV function without myocardial involvement. So what did we do? Well, so belimumab, the B-cell therapy, it was controlling her arthritis, but she was having ongoing chest pain with, quote, modest improvement in IVIG. We did this for almost 2 years. This was in the midst of the COVID pandemic. She was having all kinds of insurance disruptions with IVIG. And at that point, we repeated a cardiac MRI to kind of see where we're at. And really, these are just representative features here. But the main point to make on the slide here is that she had ongoing evidence of pericardial inflammation shown here by both increased pericardial enthickenments and late gadolinium enhancement, and she continued to have no constrictive physiology. So we really struggled at this point, and we decided at this point, given her lack of ongoing improvement in image, so we had both imaging data, we had ongoing chest pain, and we were having insurance issues with IVIG, we switched her to IL-1 inhibition with rilonacept, which I'm going to be talking more about later on in the talk. And it was really an interesting case, and I've had a number of these now because not only did her symptoms dramatically improve, when we put her on IL-1 therapy, she had to go off for belimumab at that time. We had also repeated her cardiac MRI, and this is just showing you her MRIs over time here. And what we observed was 15 months after we switched to IL-1, she had complete resolutions of symptoms and MRI findings. And this is just a recent review where we kind of go through some of the current management strategies of recurrent pericarditis within the autoimmune diseases. But this is just, as many of us may know on this session today, that we know that pericarditis can be a manifestations of a lot of our systemic autoimmune disorders. And this is just showing you kind of the different frequencies and the different groups of buckets here. But I'm not going to be focusing on this. And in fact, we're going to have the expert, Dr. Ivory, speaking in her next talk, focusing on pericardial disease in autoimmune disease. But this was really highlighting the use of the IL-1 therapy in this population. So let's take a step back. So when we think of pericardial disease, for centuries, we've known that we can have pericarditis, and in the acute phase, you can have acute inflammation that can lead to effusion and tamponade, right? Those can be life-threatening. Those are certainly what we will worry about in that acute phase. But I'm really focusing on the right here for the majority of the talk, and this is in recurrent pericarditis, because this is where a lot of the new updates have really changed the life of our patients. And then one of the most dreaded features is the constrictive physiology, which you're going to hear about in the third talk today. So just very briefly, what is the etiology of acute pericarditis? I like to put it into broad buckets. We have infectious causes. Most common would be viral, although other causes after cancer and cancer chemotherapies, as well as in trauma and pregnancy and other states. And then there's all the autoimmune related that you're going to be hear about from Dr. Ivory today, as well as the hypersensitivity. There's certain medications that have been associated, and as well as post-cardiac injury we can see. So this is just a reminder of how we diagnose acute and recurrent pericarditis. We do not have US guidelines, and so we utilize the 2015 ESC guidelines. And the basic of the talk today is really on recurrent, which is really what I want to highlight here. So acute pericarditis is both symptoms as well as some supportive findings where you have 2 of the 4 of the following criteria of either chest pain, EKG findings, effusion, or clinical exams such as pericardial rub. And that's how you would diagnose acute. But recurrence requires a symptom-free interval of 4 to 6 weeks and then a second episode. I also take care of a lot of patients in this incessant category, and these are kind of just semantics, but really just so we all know the terms. Incessant pericarditis is really where patients fail to get better beyond the 4 to 6 weeks, but less than 3 months. So if somebody is having ongoing symptoms and never really felt better, and we may be escalating to these more advanced therapies, that's technically incessant. But recurrent pericarditis does require that symptom-free. And then we define chronic pericarditis as lasting more than 3 months. So who are these pericardial disease patients? Well, here's just showing you the frequency. You can see at the top, this is a common thing we all see. It's 5% of non-ischemic chest pain in the emergency room. And we know that after an episode of acute pericarditis, the prognosis can be good. There is a minority of, it's most often good, I should say. A minority of patients will develop short-term adverse events, which can include tamponade or concomitant myocarditis. But the majority of patients with a first episode will go on to have a good prognosis and not go on to have recurrences. But when we talk about complicated pericarditis, we know that up to 15 to 30% of these acute cases can then recur. And this is really where the focus is here today. And of these recurrent pericarditis, 6% of these patients will go on to multiple recurrences. And this is a highly morbid condition and really where we have new therapies that are changing the treatment paradigm of these patients. You can see here on the right that one of our more dreaded complications is the chronic constrictive pericarditis. Luckily, it is less frequent. However, it is a very challenging problem to treat. And again, the third talk today, so getting the whole spectrum here. And going through recurrent pericarditis causes, what are some of the causes that we know about at this point in time? Well, we know that inadequate treatment of that first episode can be a predisposition for recurrent pericarditis. So what does that mean? Well, you could have too rapid tapering of anti-inflammatory therapy, so too early, or you could have the early use of corticosteroids, or rapid tapering or short courses of high doses. So we know that using them up front, that can associate it with increased risk of recurrence. Incomplete resolution to anti-inflammatory therapy is also a predictor of recurrent pericarditis. Very high levels of high C-reactive protein. So again, an acute phase reactant, we will check in these cases. And then this idiopathic etiology. And what does that mean? Well, this is kind of the emerging understanding from the mechanistic and literature that This is that underlying autoinflammatory pathophysiology, which is really driven by IL-1. And that autoinflammatory cycle that gets set up in the pericardium really creates a nidus for these ongoing recurrences. So this is the ESC guidelines for the treatment of acute and recurrent pericarditis. We can all remember how we treat acute pericarditis. First line agents is always with NSAIDs or aspirin plus the addition of colchicine. Really important, and sometimes can be forgotten, is reminding our patients that they do need to exercise restrict during these early cases. And then if you really fail that, this is really where the guidelines say it's reasonable to go to low-dose corticosteroids. And then when you get into recurrent pericarditis, the treatment is really similar here with the similar therapies. And really when you get into the third line, this is when we start getting into our DMARDs, IVIG, anakinra, azathioprine, and then last case scenario is always pericardial stripping. But this is really where the treatment paradigm is changing, is that the emerging data is that the IL-1 receptors may obviate the second line therapy with corticosteroids. We should highlight here that steroids are still the first line treatment in specific cases with autoimmune disease. Again, the second talk, you'll hear about this today. We also know that steroids are associated with significant side effects, and if they're used too early, they can have a higher risk of recurrence. And they response to those early therapies or that highly inflamed phenotype. And what's not associated with an increased risk of recurrence? I think that's also important because our patients ask us that. And we still don't understand a lot of this. This still is an area where we're having ongoing research, but we do know that younger age, gender, and having pericardial effusion is not something that we can say is really linked to that recurrent phenotype. So that's important when we see our patients. This is just one study I'm showing you here of the prognostic value of high-sensitive CRP and recurrent pericarditis. This took 106 patients with active recurrent flares, and they demonstrated in this, all the references are on the bottom left, I should mention, that 79% that had that lower high-sensitive CRP achieved clinical improvement compared to 42% with a higher CRP after a median follow-up when they were looking at this. And then they did some multivariable analysis and also demonstrated that in this cohort, they were following being younger, being on steroids, or being highly inflamed was associated with a worse prognosis. So let's move into a very quick few slides of thinking about some of the role of imaging. Here's how I kind of like to think of imaging in a broad bucket. I like to ask myself in this disease, how bad is the inflammation and what are the hemodynamic consequences? Again, truly excellent review articles have been written by the pericardial, one of the pericardial leaders, Dr. Alan Klein, as well as Paul Kramer. One of their nice references is shown here on the left. And I would like to just mention, although I'm not talking about, the talk's not focused on imaging, echocardiogram is still our first line imaging modality when we are evaluating pericardial disease. But we are learning more and more about the appreciation and the utility of cardiac MRI in pericardial disease. And so what can cardiac MRI give us? Well, not only can it give us the features of the echocardiogram, it also can actually look and quantify inflammation. So it can do the morphology of the pericardium. We can look for effusion. We can look for pericardial thickening. We can look at the degree of inflammation by late gadolinium enhancement and T2. We can also quantify ventricular size and function, as well as look at the physiological effects of constriction. This, again, is just some of the hallmarks of pericarditis that we see on cardiac MRI. We can look at the black blood spin sequence and see the pericardial thickening. This is a patient here with pericarditis, shown here with the increased thickness. We can look at T2 edema, and that is felt to represent inflammation. Remember, the pericardium, as a reminder, is an avascular structure. And so this is when you get inflammation, you get neovascularization, and then you also will get late gadolinium enhancement. I will say that some of the things that we're continuing to struggle with as we continue to learn more about about pericardial disease and their use of monitoring of cardiac MRI is when we have patients with persistent LGE in the absence of T2, because that could represent either active inflammation or fibrosis in that setting. So here's really where I'm excited to be able to talk to you about some of the updates. And this is really in the data that it's emerging in IL-1. There's been an explosion of publications. I couldn't even list them all here, but these are just some of the highlights of all the data. And pericarditis, recurrent pericarditis, is really changing the landscape of the disease. So I am trained as an immunologist, and I love to think about the immune system, and I have to talk to you guys about the role of IL-1 in this autoinflammatory cycle. So how does this occur? Where we have a pericardial injury, that insight could be various things shown here, but what happens is that activates, that pericardial damage signal activates a cascade of downstream events. The injured pericardial cells can release IL-1 alpha and other mediators. And ultimately, what you get is activation of the NLRP3, inflammasome, and that tissue damage caused by IL-1 and IL-1 beta stimulates additional IL-1 and alpha and IL-1 beta, and it creates this perpetual cycle of ongoing inflammation in the pericardium. In addition, we can see the activation of mediators such as IL-6, driving up the high sensitive CRP that we see, as well as COX, driving the fever that we can see in this pathophysiology. So what are the IL-1 inhibitors that we can utilize? Well, we have 3 different treatment options. We have anakinra, which is a recombinant IL-1 receptor. Talk about these in just a second. We have rilonacept, which is the new FDA-approved indication for recurrent pericarditis, which functions as a trap. And we have canakinumab. Canakinumab is the least used, and that's because I just showed you that pathophysiology slide of that central role of IL-1 alpha. There's very small data on this, but it's believed that IL-1 alpha is important, and also why this is the approved therapy in the middle. So how do these 3 drugs work right here? So canakinumab is fully humanized IL-1 monoclonal antibody. It binds to IL-1 beta, preventing its signal transduction. Rilonacept is here, so it has these 2 chains of the IL-1 receptor. This extends outside the cell membrane and fuse to each other. So this is how it functions as that trap. So it can neutralize either IL-1 alpha or beta as that trap receptor. Anakinra, little bit of a different molecule. It's a human recombinant IL-1 receptor. It competes with IL-1 alpha and beta here, preventing signal transduction. So in the last part of my talk, I want to talk through some of the data that's really shown us how useful the IL-1 inhibition can be in this disease, which has actually led to the approval of these indications. The first study is a small study, but an important study called the AirTrip study. This was published by Dr. Amazio and colleagues in JAMA in 2016. Small study, 21 patients, but again, this is not a common disease. But this demonstrated patients with colchicine-resistant corticosteroid-dependent recurrent pericarditis that when they randomized patients to anakinra or placebo, they had a dramatic reduction in recurrent pericarditis with anakinra. Only 2 people flared versus the majority, 9 out of 10 flaring in placebo. They then went on in the IRAP, the International Registry of the Use of Anakinra, to further support this data. This has more patients, 224, again in the steroid-dependent colchicine-resistant. And they demonstrated that a median duration of over 17 months, when they utilized anakinra, they saw dramatic reductions shown here in the blue in pericarditis recurrences, hospitalizations, ED admissions, and they were able to get patients off corticosteroids. So the next big trial to discuss with everyone is the Rhapsody trial. This is the rilonacept trial that led to the FDA approval. And here is shown here how they had a 12-week run-in period where they put 86 patients with recurrent pericarditis on rilonacept. And what they demonstrated was a dramatic reduction in both symptoms and systemic inflammation driven by CRP here compared to background therapy when they receive rilonacept. So this is just showing you that patients feel better pretty quick. The time to response was 5 days and then 7 days for the CRP. But the main money is in the trial. So what they did there is that after they did their 12-week run-in period, they then randomized 61 patients to either rilonacept or placebo. And again, similar to that air trip data, you're seeing a dramatic risk reduction with rilonacept here. In fact, a 96% risk reduction. Curves we often don't see when we're looking at coronary disease, right? But a really dramatic response rate. And this is this profound data is what led to rilonacept to get FDA approval in the United States in 2021. It is now available to our patients, which has really been a game changer. A big question in the field is really how long we treat with IL-1 inhibitors. Something I get asked almost every day. My patients ask me or others, and we're still learning this. I wanted to highlight one trial. This is the Rhapsody long-term extended data. This was published at the American Heart as an abstract, and this did, I believe, I heard will be published soon, these data, but this is their abstract data. And what they did is they took a subset of these patients from Rhapsody, and they randomized them beyond 18 months. Again, you're looking at only 33 patients here that continued therapy and 8 that went off therapy beyond those 18 months. But again, you're seeing this need for sustained IL-1 inhibition, because that even after taking a patient off therapy at 18 months, these patients in this trial, you saw they were more likely to flare than patients who sustained. So we truly don't know how long, but I certainly don't even talk to my patients about tapering beyond 1 year. And this is really where I'm utilizing cardiac MRI and other objective data, trying to make these decisions with the patient. So just a note about the IL-1 receptors, anakinra is used off-label in the US. It's not FDA approved here. We don't have a lot of data on canakinumab, and this is also less likely to be effective because of the data needing IL-1 alpha, and then we have rilonacept. Summary is that we truly don't know the exact duration of the therapy. And then another important point that I hope those studies highlighted to you is that we can taper steroids. It's feasible in these patients. And we know that corticosteroids are associated with an increased risk of recurrences and major adverse events. Thus, this is really an important advantage of IL-1 receptor. In my last few minutes of my talk here, I just wanted to go through a few practical considerations. So these are just things I do in my clinic prior to starting. I get baseline laboratory testing. I get hepatitis serologies, TB testing. Always discuss vaccination status with my patients and recommend they get them as age appropriate. And then during treatment, monitoring for safety and efficacy, and then stable monitoring of CBC and LFTs every couple months. Again, the discontinuation is really an individualized discussion, but it's really important to establish a weaning plan with a plan for monitoring of disease activity, including both inflammatory markers and imaging. Again, just a few other practical pearls when we're utilizing both our NSAIDs, colchicine and prednisone, how one can taper. But I think just a few common tips for tapering here is that tapering one class of drugs at a time when the symptoms have resolved. So we wouldn't be telling a patient to start tapering off a therapy until those symptoms have resolved and the CRP levels are coming down. We really know in this disease that you have to taper slowly. It may take several months, and be conservative with the steroid therapy and really reserve it for those patients that are refractory, and always communicating with our patients that they can still have a recurrence when they go off therapy. So just summing up here, we still have challenges in the field. There's difficulty in diagnosis. We can see poor application sometimes of the guidelines, and we currently don't have any US guidelines. I really hope one day, but so far, those have not come out. We also still need more objective criteria, such as the role of cardiac MRI, LGE, and inflammatory marker imaging. And then there's the difficulty in treating multiple recurrences, undertreated, early use of steroids, really understanding this inflammatory phenotype, and slow adoption of these new therapies. So concluding here, I know this was a whirlwind talk, but I hope that you can appreciate that we're really at a new renaissance with advances in pericarditis and diagnosis and treatment. It's really important to recognize the complexities of this disease, how we can utilize our ESC guidelines, and also additional objective findings such as cardiac MRI and high-sensitivity CRP. Understand the pathophysiology of IL-1 inhibition for the treatment, and then the role of IL-1 blockade in patients with the idiopathic recurrent, which is approved. And then that first case really highlights that we truly don't know the role of IL-1 blockade in our autoimmune diseases. Again, the perfect segue into the second talk. And with that, I just want to thank all the people I get to work at my institution, as well as multiple collaborators, including here. You can see both Dr. Boczar, Dr. Beanlands, Dr. Aiden, Dr. Ivory, and others in Ottawa. And with that, I know I'm out of time, so I will stop, and thank you guys very much.
That's fantastic. Thanks so much, Brittany. We have time for one question from the audience, and in the absence of one, I do have a question for you. I know we've spoken kind of offline about this before, but you know, I know there's varying opinions and varying clinical practices on incorporating the cardiac MRI in terms of you know, what you do. Either do you use cardiac MRI to help you wean from therapies, or to assist you in kind of guiding when to wean from therapies, or do you solely base it on either clinical or biomarker factors?
Yeah, it's such a good question, and it's one that we all struggle with. And you know, we're as more and more data is starting to emerge, and hopefully will continue to emerge in this. But I do use cardiac MRI in these patients when I'm, you know, escalating all the way to IL-1 therapy. If a patient continues to have active inflammation with supportive features, you know, LGE, T2, then I would not be weaning therapy, right? I would not. That would be giving me clues that I would not be weaning. When the MRI is completely normal and the patient's symptoms have abated, I've also weaned patients, and they still flare. So MRI is useful, but this is also why it's also not the be all, right? And that also kind of gives us the lack of we need a better imaging marker. But it is certainly a great one, but still we don't have a way to really image the actual inflammation, right, of the pericardium. The other struggle I will say, Kevin, is in the patients where they have a little bit of LGE. So, you know, we're getting more and more data on the quantification of LGE, but say they have a little mild LGE, no T2, that's still a big struggle, because whether that's active inflammation or fibrosis, and what would happen when a patient weans is really still difficult. So it's kind of a per patient discussion.
That's excellent. Thank you so much, Brittany. Thank you. That was a wonderful talk, and gave us a great kind of overview of pericardial disease, recurrent pericarditis, and, you know, where the field is moving. So next, I'd like to welcome our second speaker, Dr. Catherine Ivory, who is an assistant professor at the University of Ottawa here since 2018. She runs the lupus clinic here, and actually the lupus fellowship as well at the Ottawa Hospital. And she's certified in both internal medicine as well as rheumatology, and has a PhD in basic science from McGill as well. She is leading the immunology academic program with the rheumatology residents here in Ottawa, as well as the lupus teaching series. And she's a senior clinician investigator at the Ottawa Hospital Research Institute, and is conducting clinical trials and translational research in rheumatology, mainly being in lupus. Her research is ongoing both in immunology as well as inflammation, as it relates to the pathogenesis of rheumatic disease. And I'd like to turn the floor over to Catherine, who will kind of tell us about the overlap between pericardial disease and rheumatology. So thank you.
Great, thank you, Kevin. It's a pleasure to be here. Again, Brittany kind of had a good segue into this, and I'll try and do an overview of pericardial disease with respect to rheumatological conditions. It's quite a large body of to go through, but again, an overview if we can, and hopefully I will answer some of those questions you may think about, and if there's time at the end, we'll go through them. These are my disclosures, because I'm a rheumatologist. There are lots, but none that pertain to this talk. So just overall, when we think about cardiovascular disease and rheumatic conditions, we can see that it can affect all parts of the heart, from the myocardial to the conduction system and valvular disease. But for the sake of today, we'll just focus on pericardial manifestations. But clearly, there's a big overlap with cardiology and rheumatology, given the heart involvement with our patients. And Dr. Weber talked about lupus, but clearly that's on the top of the list, but there are many, if not all, rheumatologic condition can manifest with pericardial disease. Lupus is on the top of the list. It's kind of one of the more common manifestations that we see in lupus patients when they have cardiac involvement, and lupus is fairly common, so we probably would see more lupus with pericardial disease and other rheumatic conditions. But there's also a prevalence in rheumatoid arthritis. Anywhere between 30 to 50% of patients at some point in the course of their disease will have pericardial involvement. Vasculitis, again, that's a big group of diseases, and in terms of which ones would more likely manifest with rheumatic pericardial involvement, EGPA, which is eosinophilic granulomatosis with polyangiitis, has the most pericardial involvement of all the vasculitides. However, that entity itself is quite rare, so we wouldn't expect to see a lot of cases related to vasculitis and heart involvement, specifically the pericardium, whereas GPA and MPA are more common as a vasculitis and can develop pericardial involvement. And then as you go down that list, they're less common, but again, there will be case reports and case series of people presenting with pericardial disease with any of these manifestations. Scleroderma is an interesting one because they can present with sort of a variety of pericardial manifestations. So both acute pericarditis, some chronic, maybe low-grade recurring pericarditis, and then they also can develop this slow-growing fibrotic change in the pericardium that may be asymptomatic. And a lot of the times those are found post-mortem or, incidentally when they're looking for something else. They can also develop pericardial effusions and tamponade, although luckily not that common. It has been seen. Anything that's connective tissue disease can still, present with pericardial involvement, but again, lupus and rheumatoid arthritis being the most common. The next highlighted one is familial Mediterranean fever, which is an autoinflammatory syndrome driven often with IL-1 and anti-TNF, which is what we see in terms of the serositis that they get in pericardial involvement. But this is usually something that presents in childhood, but can go through into adulthood, and they would have repeated bouts of inflammation, so can present like a recurring pericarditis. Although typically, depending where you are in the world, you may not see as much of this presentation as you would, geographically where it's more endemic. And then the list goes on, but all of these conditions are less likely. But just to show that there's a huge breadth of rheumatological manifestations that can happen within each of these diseases, and with respect to pericardial disease, it can really go across the board. But you should think more about lupus and RA as well as vasculitis as your top differential. This was the same slide that Dr. Weber presented, but it just highlights in those buckets of where we would classify the diseases where we have pericardial involvement. And within those buckets, the top ones are bigger and again represent lupus, EGPA, familial Mediterranean fever, and then at the bottom we have sarcoidosis and IgG4. Those are infiltrative diseases. A lot harder to diagnose if it's the first presentation for the patient, because you would have to have tissue diagnosis, and it's a diagnosis of exclusion. So often there's a big workup that goes into identifying that as the cause of their pericardial disease. For presentations in rheumatic conditions with pericardial involvement, it should be the same as what you would expect. So if it's an acute pericarditis, they have chest pain, the typical changes on ECG and imaging findings. We would expect that if it's from an underlying rheumatic disease, they would present during a flare. So they may have other symptoms of the disease, so rash, arthritis, lung involvement, and maybe some renal disease. But if they present as their first presentation with pericarditis as the only manifestation that is rare but has been reported, it may be more difficult at that point to pinpoint that it's related to a rheumatic disease. So I think a lot of these patients may be treated as an acute pericarditis, and then they recur, and that's when you might think about doing a workup for an underlying rheumatic disease. So if no identifiable cause is found and your review systems is otherwise negative, I think it would be reasonable to do a workup to see if they may have just pericarditis as their main manifestation, and then look for autoantibodies. You wouldn't have to send for everything that exists, but a good workup would have an ANA, which screens for basically most of your connective tissue diseases, RF and CCP for arthritis, ANCA for the vasculitides, and then I would throw in a urinalysis because sometimes that'll help see if there's nephritis, which we'd see with vasculitis and lupus, which would hint towards another organ involvement. And of course, the ESR-CRP, which would expect to be elevated in acute pericarditis. The presentation can be slightly different as well in rheumatic disease, whereby some patients are asymptomatic, so they don't present with acute pericarditis, but they have slow-growing effusions, or with scleroderma, for example, they may have this fibrotic process that's happening over years. And if they're not someone that's very active, they may not report dyspnea, and so it may be found incidentally later in the course of their disease. But usually with the typical presentation, there's high inflammation, as mentioned by Dr. Weber, and that can help us also differentiate between an infectious process, lupus, or perhaps cancer. There are risk factors in rheumatic disease for patients developing pericardial manifestations. Usually, it would be someone who has active disease. So if it's their first presentation of autoimmune disease, they're clearly not on treatment. So they may have more organ involvement than they would if they were well controlled. They may have just suboptimal disease control because they've only just started therapy, so they're not really immunosuppressed to the full potential. And so they may have fluctuations in their disease and more likely to flare. Of course, same as you see in cardiology, patients are non-compliant, and if they're not taking the medications, they're more likely to flare. The immunosuppression itself, I think, brings into question sometimes the trigger for the pericarditis. So we would assume it is from the disease, but those patients are immunosuppressed, so they're also more likely to just catch the run-of-the-mill viral triggers that we would see for pericarditis. The treatment will still be the same, but then sometimes it goes back to the rheumatologist to decide if it was a true flare of the actual autoimmune disease, or was it just that they caught an infection because of their immunosuppression. And then if it's something I think that's recurring, like the case of Dr. Weber presenting, perhaps you look at changing therapy, or in some cases look for those more tropical or atypical infectious causes, or even cancer in some patients, because their risk will be higher because of immunosuppression and their autoimmune disease. In the literature, it's a little bit unclear, but there are patterns that would show that depending on the disease that they have, there are some markers that may predispose them to developing cardiac involvement, including most likely pericardial disease. So with lupus, in a big cohort in China, the male patients, so there's less lupus in males in general, but the male patients tended to have more pericardial disease. Those patients across the board, male or female, that were anti-Smith, anti-dsDNA, and RNP positive tended to have more pericardial involvement. And patients with active nephritis, so proteinuria, also tend to have more disease flare and more organ involvement, and have propensity to develop pericardial involvement. In rheumatoid arthritis, it's the same for any organ involvement that is extra-articular. If they're high anti-CCP, they're more likely to develop pericardial disease. And with vasculitis, this is a little bit of contradictory in a sense, but with those vasculitides that are not eosinophilic, so GPA and MPA, the high ANCA titers can predispose to more organ involvement, therefore pericardial disease. Whereas with EGPA, which is the one where it's most common, it's an inverse correlation where those patients usually are ANCA negative. The exact mechanism as to why, I'm not sure. But so for us, when we do these autoantibodies, it's also for diagnostic purposes, but it can help prognosticate disease involvement in the course of their trajectory with the disease. The approach to treatment we've already gone through. It's basically the same as you would do for any pericarditis, although there's going to be some nuances as to how we treat our patients with an underlying rheumatic disease. So if they have an acute flare of their disease, they may have renal involvement, CNS involvement, so something that would make us want to use higher dose steroids and perhaps for a longer course. If they have a new diagnosis and it clearly fits with one of these connective tissue diseases, we're going to want to start DMARD therapy very quickly and overlap it with steroids so that as the steroids are tapered, the other drugs are starting to take effect. We have disease-specific biologics, which would probably be implemented as soon as we can as well, depending on coverage. It's different between the US and each province, but we do have access to biologics for most of these rheumatic conditions. We still use NSAIDs, again, depending on comorbidities. Often with lupus, the patients have nephritis, and we would avoid NSAIDs. A lot of our patients may have antiphospholipid antibody syndrome, so we have to be careful with steroid use and as well just with any NSAIDs. And the steroids, because they have possibly already a diagnosis when they come in with pericarditis, usually easier to increase the steroid dose as opposed to adding an NSAID. And then that taper will sometimes take a bit longer, I think, than if it's just one organ involvement. Colchicine we still use. There's great evidence for that in rheumatic disease. IVIG, I think it depends where you practice. In Ottawa right now, it's very hard to get patients in for outpatient treatment. It is covered by our Ministry of Health, but we don't have spots to bring them in for IVIG. And I'm not going to berate over the IL-1 because it's more specific to the idiopathic types. It can be used obviously with rheumatic disease, but we often have other biologic therapies that are more specific at treating other disease manifestations. So we'd usually reserve the IL-1s for those, like Dr. Weber's case, where they have recurrent refractory pericarditis, but otherwise we would use more lupus-specific therapies, for example. And for us in Canada, we don't have Health Canada approval, as far as I know, for any IL-1s yet. So it would all be off-label use, and it has been difficult to get coverage unless they have private insurance. If the patient does have one of the approved indications, so RA, Still's disease, or JIA, then it's much easier to access. And we have used them in those cases where they have a lot of serositis, including pericardial disease. So I think I still have some time. I just wanted to show two different cases, both with lupus, because it's the most common one that we see, but very different presentations. So the first woman, she was diagnosed in Ghana, so I don't have those records, but her main manifestation had been pericarditis with some myocardial involvement as well. She moved here from Ghana after having treated with steroids. She was on hydroxychloroquine, but no other lupus therapy. She hadn't really had much else in terms of disease manifestation. So when she moved to Canada, she did not have a primary care physician or a rheumatologist. And unfortunately, she flared. She ended up in hospital in the emergency departments with classic symptoms of recurrence of pericarditis. I think there was no myocardial involvement at that time, high CRP and high dsDNA. Appropriately, the team in the hospital gave her prednisone and colchicine and referred her to rheumatology. She clearly had lupus as the underlying cause, so we treated her with mycophenolate. She had a little bit of kidney disease as well, which is why I chose that particular DMARD. We tapered her prednisone over time, and eventually when she was asymptomatic, we stopped both the colchicine and the prednisone. She was well for a while, but unfortunately recurred with pericarditis again and emerged 2 months later. And then the thought process for us at that time was whether this was still caused from active lupus, because she only recently had started her therapy. Mycophenolate and most of the DMARDs that we use, including azathioprine on the guidelines, take about 3 to 6 months to really reach full therapeutic potential. So there's a window of time where the patient may not be immunosuppressed to the point where their disease is controlled, but they're still immunosuppressed enough to catch viral infections and not feel well. And she'd had some viral symptoms, so I wasn't sure which one was causing the flare. Either way, she required a course of steroids again with colchicine, but as she continued on the mycophenolate throughout, her lupus has been well controlled and she has not recurred yet. So if there's an underlying rheumatic disease and we're able to control the disease, usually there shouldn't be any recurrence of pericardial involvement, but there are always exceptions. The second case, again, lupus, a slightly older female that I recently inherited. She has long-standing lupus diagnosed about over 15 years ago. She also has sickle cell disease, which has been harder to treat, requiring red blood cell transfusions and apheresis. But her main manifestation from lupus was hepatitis and recurrent pericarditis. Again, it's not well documented over those years. She would go to different hospitals, hard to follow the records. But presumably, as per the patient, for the last 10 years, she's not had acute pericarditis and no symptoms to suggest her lupus has been active. She's treated with low-dose prednisone, more so for the autoimmune hepatitis, and then azathioprine for lupus and the hepatitis, and has been doing really well. Our measures of disease activity would put her lupus at very low activity, and she only gets points for having positive serology. But then we were reviewing her chart, and the reason she was referred to me was she has a very large pericardial effusion on MRI. It's 30 by 30 millimeters, about that. But she's completely asymptomatic, no chest pain, no dyspnea. She's not a very active person, but does not complain. And there are no signs of tamponade on imaging. And she was seen by her colleagues in cardiology, and they suggested we should probably remove some of that fluid to reduce that risk of tamponade, but she's not really interested in any procedural change. Doesn't want any procedures, definitely no surgery. And from my standpoint, from a lupus, I don't have any indication to necessarily treat her. The MRIs, as far as I know, don't show active inflammation anymore, which is another reason why I wouldn't increase her therapy. So some of those cases are a bit more tricky because it clearly is probably an autoimmune driven process, but the exact way to treat her is not as clear. But she'll require some of that close monitoring with cardiology for more specific imaging. And if there's an intervention, I'm going to need their help. So that was all I had. The overlap really is going to be in those patients where they have known disease and they present with pericarditis. A lot of the times, I think the rheumatologist can identify it and treat it. But if there's going to be a recurrent, then we may need more specific imaging or other ways to monitor the disease. If the patient presents initially with pericarditis as their first present manifestation of disease, then that initial workup may come from the emerge physician or the cardiologist, and then referring to rheumatology would definitely be encouraged. If there's help needed for initiation of DMARD therapy, most of us are quite collaborative, and now there's this pericarditis clinic, so we can help out there too as well. And then I guess it's going to be different in each province or where you practice in the world. The access to the IL-1 blockade, that's usually an issue, but we have experience in rheumatology starting biologics and ordering the biologics, and Dr. Weber gave a good outline of what to do before. So it's important to rule out TB and hepatitis because they can have a reactivation of latent disease. And then our patients usually will tolerate these medications well, but they need close monitoring. Thank you.
That's great. Thank you so much, Catherine. That was awesome. You know, this question's for you, but I'll also open it up to Vartan and Brittany, just in terms of, and I see Brittany has her hand up as well. You know, one thing that I know I struggle with, and you know, my colleagues struggle with, is when to pull the trigger to, you know, send for an autoimmune workup. You know, you kind of alluded to it in your presentation. But, are there circumstances where, an initial presentation of pericarditis in your mind would trigger an autoimmune workup? Yeah, I'll pose that to you and the group as well.
Yes. I mean, if it's the only manifestation they have, definitely it can be difficult. You do your quick review systems and they have clearly nothing else they complain about. Maybe no known risk factors for autoimmune disease. So like for rheumatoid arthritis, a smoker is more at risk of developing anti-CCP antibodies. They're more at risk of then developing RA. If they have the family history, that kind of thing. But if they clearly have no other symptoms, I think, yes, it would be hard to kind of pull that plug and do it. And then how do you interpret the blood work? Because we know if you just do an ANA on everyone here in the panel, about 20% of us will be positive. So yeah, I'm not sure how to answer that, but I think if it's clearly driven by an autoimmune disease and they don't end up on long-term therapy, they usually relapse with either pericarditis again, or they develop other symptoms of the disease. Because it would be rare for someone to have rheumatoid arthritis and only ever develop extra articular manifestations. So perhaps those recurring cases that you think are not necessarily idiopathic, but could have an underlying autoantibody. I think that's when I would probably do the workup. But Brittany, you guys have probably done it more often than I have.
No, that was excellent, Dr. Ivory. I love listening to this talk because this is actually what I see the most of because with the cardio room clinic is lots of pericardial disease within autoimmunity. And I do the exact same thing, Kevin, is that I really guide it by clinical history, but I take a really good clinical history. I still remember one patient that was given a diagnosis of pericarditis in the emergency room, and then, did not get it really any treatment, was young in her 20s, came to me in my clinic, and I'm going through a review of systems. She had a CT, and it was like really, thickened, consistent with pericarditis, did not have any other imaging at the time, not even actually an echo. She was telling me she had alopecia. And as Dr. Ivory knows, she was going through some things, and I was like, oh, this just is it. And she was really bothered by her hair. And so I didn't send a full panel. I started with our ANAs with reflex and a few labs, and it came off the charts. And then our panel will reflex the double strand DNA. But it was really important because she, as mentioned, I had a UA and she had protein in there. And the reason, one, we diagnosed lupus, but she actually had lupus nephritis, which, as you guys know, as rheumatologists know, we treat seriously. So I really take a good clinical history and send it based on that. And I think it's always important that if we check an ANA, we always make sure we educate whoever else is checking it that it does not mean they have the autoimmune disorder, even in the setting of pericardial disease, just because up to, a third of the population can even have it at some point. Catherine, I wanted to ask you one question on your talk, and I know that we all have different experiences on what we can get between US, Canada, and even Europe. But when you do have to go on to like IL-1s or other therapies, do you ever combine biologics, or do you usually stop? And it's always a challenging question that comes up in this kind of refractory treatment population is, I think we all have a little pause with combining biologics, but it is done, right?
I guess the beauty with the IL-1 inhibition, for us with Kineret or anakinra, it's a daily injection, so it's very quick on, quick off. So you might be able to use it for a shorter period of time, perhaps. Canakinumab is much longer half-life, and ranolixaft as well. I think, yes, we're always a bit itchy about combining biologics. So I think I don't have that much experience combining them because I usually just switch. Like if it's for pericarditis, we'll
switch over
the other things. But I might say keep their mycophenolate or keep isothioprin or another DMARD with it. That's fine. Biologics,
yeah. This is what we've done. Like the belimumab patient, we thought, well, it's a B cell versus IL-1. It probably would be okay, but we ended up stopping it because we just didn't really want to do the dance. But I actually have a few, at least more than one patient with psoriatic disease where we've kept them on their IL-23 inhibitor because their they're too bothered, they flared with their skin disease, and that the dermatologist also felt was safe. But it's always this kind of uneasy area, right? Because the infection risk of.
Yeah, no, there's not a lot of data out there either about the safety, because there's none of those companies will ever okay us using them together.
Right? Yeah, exactly.
But if the patient is aware and everyone's monitoring closely, it does, because I know in GI, they often have to combine as well.
Yeah.
But they'll often use vedolizumab, which is gut specific and then doesn't have as much systemic issues. But yes, in rheumatology, we're usually very scared about combining those things.
Exactly. And you highlighted EGPA being one of the most common in it. And I agree. And it's rare, but something we probably do see. And I have and I'm just even thinking through my case where we needed to go on Dupixent, and we were like, oh, we actually kept a brief overlap for a while, thinking that those were very far different biologics. But again, just kind of the unknown charted territory we're in. So
yeah, exactly.
That's great.
I have a quick comment too. I agree 100%. There's one biologic that I don't like combining with anakinra. It's the anti-TNFs. I'm not such a great fan of it because we have data from rheumatoid arthritis literature that there's higher rates of infection. But the ones that I have used in combination is, well, like you said, in the psoriatic patients, I have had 3 or 4 of them that I had to continue using their agent. But often I have them on like Kineret 3 times a week. They're on a lower amount of the Kineret, and it works fine. And the other one I've had in some RA patients is some of them have continued with Xeljanz or one of these oral like JAK inhibitors while they're on Kineret, and they're on like 3 times a week of Kineret or something like this. It has worked fine also. So those are the only 2 settings in which I've continued like some sort of combination. But the definite no-nos are the anti-TNFs, and the few cases that I had with belimumab, I didn't have the courage to keep both. So we stopped, but it was problematic because it was the exact same thing. The belimumab didn't control the pericarditis, had to be stopped and go back on Kineret. It was complicated.
Yeah, I think the pericarditis, as you alluded to with your talk with NLRP3 and the DAMPs, it's more of an innate issue less than B cell related, and that's why it doesn't work.
Exactly. That's what, and agree. I agree, Vartan. In the US FDA approval of rilonacept, TNFs is a black box no-go. So it's not even allowed in the guidelines in that setting, but agree.
That's great. Thank you, guys. I see one question from the audience before we transition to Vartan's talk. So Andy asked for Catherine, how often do we see pericarditis in the absence of other symptoms in patients with lupus? And some context in that they often see rheumatologists reluctant to increase lupus therapy when pericarditis is the only manifestation of the disease, and they're not responding to pulse steroids or colchicine.
I tried to look for that exact number. I don't know if Brittany's come across. I couldn't find a study that had an exact number as to how many present with a sole presentation of serositis. It's probably quite rare. And then the question, is it actually lupus is always the question. Or is it just that they have a positive ANA and maybe they have a positive dsDNA, but like by all criteria for lupus, you have to have more than one clinical manifestation. So then I think it's just semantics. If you call it lupus, you may have access to treatments. Then they have positive antibodies. They may respond to azathioprine or even mycophenolate. So yeah, I think it depends on the room, because I think if they have positive antibodies and that's all their manifestation, I guess it becomes more of who's managing what, I guess, because if they don't have lupus, then they may just need a cardiologist. So it's kind of a I'm not sure how to answer that one.
One of the answers to this too is like when people have these systemic disorders, I think a lot of the treatment would tailor it to what's dominating as the problem. And if something is like less dominant and minor, sometimes we leave it. One of my early cases, like years ago, over a decade ago, when I started using anakinra, wasn't a lupus patient that I started hesitantly. There was many manifestations. There was the double-stranded DNA, there was thrombocytopenia, and so on. On corticosteroids, was doing well, but severe side effects from the corticosteroids had to be switched to anakinra. And then when I started anakinra, the pericarditis had excellent control, but the thrombocytopenia was back, and all the other stuff that were controlled with the corticosteroid was not present. And I'd spoken to the rheumatologist and said, you know what, mild thrombocytopenia, even they consider that mild, so it doesn't need to be treated. So just focus on the pericarditis, because that was the dominating problem that was resulting in recurrent hospital admissions. There was no nephritis, there was none of the other bad stuff. So she was on like monotherapy interleukin-1 inhibitor and didn't require anything else. So I think that we look at what's dominating, what's the big problem, and we focus on that. And this is also happening with like some of these cancer therapies that are resulting in the immune system getting activated. We're just treating whichever one is like the dominating problem and dealing with it that way.
I see,
The,
Andy, that the case he was referring to had lupus at baseline on therapy, but all else quiet. Yeah, I think if there's still lupus, I guess at baseline, and pericarditis, that's active disease. So I don't know why that rheumatologist would not want to increase therapy.
The one, I completely agree. And the only additional piece I can add is, and I wish I had the reference, but there is, Andy, if you do a search, there is a cardiac MRI study that took kind of lupus patients and did cardiac MRIs, and they describe the frequency of cardiovascular manifestations and pericardial findings. I want to say were at least up to 30 or 40%. Many of those didn't even have symptoms. So that is a piece of data to suggest that it's quite common if you were to just MRI, a whole cohort.
Yeah, for sure. But then I don't know how many. If they're asymptomatic, they're not going to
how much
diagnose it. So
exactly. Like, what do you do if you see it on MRI? Exactly. That's what you guys were just saying. But
it's a
great. Thank you, guys. That was a wonderful discussion, and thanks Andy for that question. So last but not least, Vartan Mardigyan is up. So Vartan completed his cardiology training, echo training, and rhythm device fellowship at the McGill University. He's an assistant professor of medicine at McGill and is a cardiologist at the Jewish General Hospital. He works in general cardiology, echocardiography, as well as pacing. And he also has an additional focus and interest in the diagnosis and management of pericardial diseases. And, on a personal note, Vartan was so helpful for me getting set up here in Ottawa, the Pericardial Clinic. So thank you, Vartan, for joining us today. And I pass the floor over to you on your talk on constrictive pericarditis.
Thank you very much, Kevin. Thanks to all the other speakers as well. So just gonna go on to the next slide. Yeah, I have no conflict of interest to disclose. Just before I go on with the subject, I just want to guide you towards a special issue of the Canadian Journal of Cardiology that we took the time to prepare and we published in August 2023, specifically looking at pericardial diseases. It was an international collaboration of many authors. We went through every subjects of refractory pericarditis, constriction, surgical aspects, imaging aspects. There's around like 10, 12 manuscripts in there. And one of them was on constrictive pericarditis. It was a short contemporary approach. And some of the things in today's talk is going to be from that manuscript in the CJC. So the framework in which we made this slide is from the diagnosis to the imaging, and then afterwards looking at whether inflammation is present or absent, and then from which patients are going to be treated with anti-inflammatories, which ones are going to go to pericardiectomy, and the perisurgical planning. So this is the framework in which we made that paper and made this slide. And today we're going to go over some cases to look at that as well. So for the objectives, we're going to describe the classical presentation of constrictive pericarditis, what the relevant investigations are to establish the diagnosis and to plan treatment, relevant questions to raise in the patients who have systemic venous congestion, review illustrative cases, and review outcomes according to pericardiectomy in the first part. And the second part, if we have time, I'm going to go into more detail of the surgical aspects and looking at transient versus permanent constrictive pericarditis, comorbidities and concomitant diseases in patient going for surgery, which factor into your decision-making, limited pericardiectomy versus complete pericardiectomy, and the use of cardiopulmonary bypass during pericardiectomy. So constrictive pericarditis, in how we see it in cardiology generally, is usually a heart failure presentation. Patients come in with heart failure right more than left, often with effusions, ascites, lymphedema, etc. And in its purest form, it's when you have the pericardial restraint without any disease of the myocardium or the valves. However, as you know, there may be situations when there's overlap, but this is what we focus on in terms of what we speak about pure constriction, okay? Usually on imaging, the pericardium is thickened. Often, if the disease has been going on for many years, like decades, usually it's calcified as well, the pericardium. However, there are some cases where the pericardium could have relatively normal thickness and still have constriction. The most important finding that we're looking for in different imaging is the presence of ventricular interdependence. Whether it's on imaging or other types of findings that we're looking at, is mainly the ventricular interdependence. So regarding the diagnosis, like I said already, patients present with a variety of symptoms, but most of what you're seeing is a heart failure type presentation with elevated JVP, prominent X and Y descents, ascites, lymphedema. On echo, you usually have the dilated IVC, which is a common finding, almost universal in the patients. And on the physical exam, this was from a patient who was going to go for pericardiectomy, is the very typical elevated JVP with the prominent X and Y descents. If you see a lot of these, you see it's very typical and very common in these patients. What is the pathophysiology of these patients? When the pericardium is thick and tense, even in the absence of myocardial disease, it will impair the filling of the heart. And the way in which the impairment of this filling occurs is respirophasic. When the patient's breathing, the flows are changing inside the heart, and that's what we use in order to establish a diagnosis. So when the patient takes a breath in, this inspiratory effect drops the pressure in the pulmonary veins enough that the flow going towards the LA drops, because the LA doesn't see it as much as in the PVs. So that small gradient of forward flow drops during inspiration, and the LA gets underfilled, and then the LV gets underfilled, and the septum shifts and flattens during inspiration. And this is the thing that we're looking at on echo, on MRI, etc. And then when the patient breathes out, then the right side has the impaired filling, and then the left fills. So essentially, the left preferentially is filling during expiration, the left heart. This is the main pathophysiology. And when we do echo, this is what we find. And the key is when you're evaluating somebody for constriction is to have multi-beat acquisitions in order to see this finding, okay? That's in long axis. And here in short axis, you see when the patient breathes, the diaphragm comes down, the flattening of the interventricular septum. And here in this patient, you also see the thickened pericardium in front of the right ventricle as well. However, if you take it as a one-beat clip like this, you could say, hey, this looks like a normal heart. Why does this patient have heart failure? So the importance of doing the multi-beat clip, especially the person scanning, the technician, when they see those abnormal findings, to do the multi-beat clip in order to show the interpreter what the abnormality is present there. Regarding the CT, what I talked about before, the presence of thickening and calcifications is very useful on CT, one of the important reasons for which we use CT. And then on the MRI, again, we're looking at this finding when the patient breathes in, the diaphragm comes down, the flattening of the interventricular septum with respiration, okay? And there's another case, similar kind of thing. All these patients that we had sent for pericardiectomy who had this typical finding during respiration. On the invasive testing, on the coronary, on the cardiac catheterization, we're looking at an indirect thing of the same, an indirect measurement of the same thing. Is when the patient's breathing in, on the left side, the LV pressure systolic is dropping, whereas on the right, it's either staying same or going up. This is an indicator, this finding is an indicator of the interdependence, okay? Whereas in a normal situation or in cardiomyopathy, you don't have that, and the pressures dropped equally during inspiration. So you have the right heart failure findings with typical imaging findings of the ventricular interdependence, which is consistent with constrictive pericarditis, or you might corroborate with catheterization findings as well. Now, the next step is to determine whether there is any ongoing or active pericardial inflammation with measurement of CRP or cardiac MRI, or are you dealing with someone who has majority scar, in which case you're planifying mainly surgery. The other thing that you're simultaneously looking at is, was there a specific etiology of why this patient has developed constriction? Was there a history at some point where they had refractory pericarditis, they were hospitalized? Was there a history of TB? Was there a history of other disorders and so on? Has there been a history of radiotherapy, previous cardiac surgery, et cetera? You're looking at also determining why this patient had it as well, which factors into some of your decision-making. And finally, the presence or absence of myocardial disease and the presence or absence of valvular disease impacts on how you plan the surgery. So most of these patients in their evaluation get an echo with the lung loops, et cetera, that we talked about. chest x-ray, because some of these patients also have pleural effusions, whether it's due to the heart failure, or sometimes they have inflammation in the pleura, they may have entrapped lung, etc. as well. So x-ray is important there. And CT, MRI, for the reasons that we explained. And cardiac catheterization, we usually do it in two situations. One is when we're planifying surgery. We like to do it in order to do the coronary angiogram, and also to look at the cardiac output and the cardiac index prior to surgery, because one of the most important determinants of whether the patient is going to have low cardiac output syndrome after pericardiectomy. However, we don't use it specifically for diagnosis. Most of the patients that when we're sending for cardiac catheterization, the diagnosis is usually established already by echo and MRI. On echo, the four things that we look at: IVC plethora, and then the next thing we're looking at is the ventricular septal shift with respiration, as I showed you. And then if those two are present, usually you're looking at a situation where constriction is highly likely. And the two other supporting findings is the medial E velocity being high, and in particular being higher than the lateral E velocity, which is the reverse of what you usually expect, and the hepatic vein D wave reversal during expiration, which typically looks like this. If you have a good hepatic vein tracing, often one of the limitations of this is poor hepatic vein tracings during when you get it. But if you actually get a good tracing and it looks like this, it's usually a supportive finding. So therefore, suspected constriction, you use the echo to screen, and then after you may end up using some cross-sectional imaging such as CT or MRI. Then is there inflammation, yes or no? And then that's when you're going to go towards whether you're going to do medical therapy or are you going towards surgery. So here I'm going to start with a case in order to illustrate some things. So this is a patient who came with like pleuritic chest pains, dyspnea, very kind of pericarditis type picture. 3 weeks of symptoms ongoing, dyspnea, low-grade fevers, and she was starting to have edema, elevated JVP, tachycardia, etc. And then they discovered that she had a significant pericardial effusion with a dilated IVC, very high CRP, 209, and a left pleural effusion. Her chest X-ray demonstrated the enlarged cardiopericardial silhouette and the pleural effusion. Echo showed a significant pericardial effusion without frank tamponade, dilated IVC, and some fibrinous material and thickening within the pericardium. She met two of the criteria of being inflammatory pericarditis, which is the pericarditic type chest pain with the pericardial effusion, and there was an elevated CRP. So we did think there was active inflammation for sure. We started the patient on anti-inflammatory therapy, and we discussed the risks and benefits of doing a pericardiocentesis. We had seen here that it looked like relatively safe pericardiocentesis, and we believe that there might be some small diagnostic value in getting the fluid as well. So we did it for both diagnostic and therapeutic reasons. So we did the pericardiocentesis, sent it for analysis, and so on. Nothing specific came back in terms of the testing. However, the important finding that we had here was that 48 hours after the drainage and the initiation of anti-inflammatory therapy, this patient had an echo that was done to look at the effusion. What you were seeing is that, look, there's a significant marked pericardial thickening that's present here. You see behind the RA, it's a typical location here, what we call a pericardial rind, and the ventricular interdependence is present, the respirophasic shift, okay? Same thing that we're seeing here is septal bounce, and then when the patient breathes in, there's some flattening, and the IVC remains dilated, okay? And this is the tracing, the hepatic vein tracing from that patient, actually, like I showed the previous one, showing the D wave reversal. And we did a cardiac MRI, showed two things. One, the presence of constrictive physiology, all right, with the flattening when the patient's breathing in. And the second was a dense rim of thick pericardial LGE that was present, okay, on the images. So what is this? Different terms are used for this. So one of the classical terms, there's an old one, which is called effusive constrictive pericarditis, in which situation where you drain the pericardial effusion, however, the RA pressure remains elevated. It's like an old definition that was used. And what are these? These are often the ones that are also the transient constrictions, the ones that are inflamed, and removing the fluid is not sufficient to treat this patient. You also have to target and treat the inflammation, okay? So how it was initially diagnosed is patient would have a large effusion and they'd have a catheter, for example, in the right atrium and a catheter in the pericardium, both of them being high because the patient has increased intrapericardial pressure. Let's say they're both at 20. Then you bring down the pericardial pressure to 0 by draining the entire thing. and then the right atrial pressure remains high, and you have a tracing that looks like constriction with a prominent X and Y descents. That's how it was initially described. Now we have echo and MRI and all other ways of diagnosing this. We rarely do a right heart catheterization at the same time as a pericardial drainage. So this patient was treated with anti-inflammatory therapies. The CRP normalized, symptoms improved over time. IVC got normal, and the echo at follow-up showed like complete resolution of that pericardial thickening, and all of the constrictive findings went away, and the echo was normal at follow-up, highlighting the transient nature of that constriction. So post-pericardiocentesis, one of the questions we ask is, okay, have you drained the fluid completely? Has the IVC remained dilated? Are the neck veins still distended? Are there findings to suggest the presence of constrictive physiology? Is the CRP still high? Is there LG on MRI? These might be findings that you might target to treat the transient constriction. Now, here I show another case. This patient has not had a drainage. This patient, first presentation, several weeks of symptoms of a pericarditis type picture, very high CRP, but you see there's like a dense rim of pericardial thickening, dilated IVC, septal bounce, same disease, same pathophysiology, required to be treated with anti-inflammatories, and then 2 weeks later, there's a complete resolution of all the constrictive findings. Again, transient constriction, but in this case, you didn't have to do any drainage. It's the same thing. And here's a case with a very small effusion, but again, having the signs of constriction, very thickened pericardium, etc., having the interdependence. I'll not skip over these. So the prognosis of patients who come with a pericarditis type picture is determined by the etiology and not the number of recurrences. Although we get scared of the number of recurrences, if those recurrences are short-lived and treated, they usually don't tend to progress to constriction. The ones that do end up going to constriction are the ones that are not well treated, are incessant, and go on for weeks and weeks and weeks. And some of the scenarios in which this does happen, and I've encountered, is when patients, for example, are after cardiac surgery, are very inflamed pericardium, etc., and are incompletely or undertreated. And when it goes on for 8 weeks, 12 weeks of a dense, thick pericardial rim like that with constrictive findings, they often start to get into the spectrum of being permanent constriction. And you may lose that opportunity or that window of opportunity to reverse the inflammation when it's happening, or if the patient presented very late for whatever reason. So this term transient constriction, the echocardiographic definition of this transient constriction is probably better than the classical hemodynamic definition because we have access to the echo, is the presence of the respirophasic change and persistent dilated IVC after pericardial drainage. Effusive constrictive pericarditis is more common than we originally reported. The more people are looking in the acute pericarditis type phase, the more they're seeing that some of these patients do have these transient constrictive findings, up to 15 to 20%, even in some of the post-drainage cases of acute pericardial inflammation with tamponade. Most cases are reversible if you treat and get rid of the inflammation. And it's important to follow them closely to see that after complete biochemical and imaging resolution, if the inflammation has the transient constrictive physiology also gone completely away, because some of the patients have developed some scar, but not enough scar that it requires surgery. You still have some findings at the end, but you may have like evaded surgery by getting rid of an important component of it. So at the beginning, when a large component of it is inflammation, you have an opportunity to reverse it medically. But as time goes by and weeks go by, typically when you're beyond 8 to 12 weeks of incessant inflammation, you're starting to get scar tissue. And this is what we call burnt out or, calcific, thick. The calcific actually, I want to make a specific thing to that, is that calcific is usually decades after. Sometimes when you start seeing calcified pericardium and they give you the history, you're talking a history of like very long-standing or old pericarditis. But once you have no more T2, no more delayed enhancement on MRI, it's all constriction, CRP is normal, you've probably missed the opportunity to treat the inflammation. So regarding the etiologies of patients that go for pericardiectomy, the two biggest groups that have published on this is from Cleveland Clinic and Mayo Clinic, mostly in patients that are going for constrictive pericarditis. And they break down into 3 broad categories, which is the idiopathic, most common, post-surgical, and post-radiotherapy. These large centers doing a lot of surgery, like Mayo Clinic and Cleveland Clinic, do about one a week. And other centers, which are considered high volume centers, even like ours, we're looking more like 5 to 10 a year, even with a large catchment area. Mayo Clinic and Cleveland Clinic are a bit special because they have such a huge catchment area of the entire United States sending them surgery, so they have the largest experience. So getting back to this slide I had already showed, now the specific aspects of the surgery, then I'm going to come back to the prognosis, is the fact that when you have scar tissue and that scar tissue is creating pericardial restraint, the only way you have left to deal with this is to remove that area that's creating the pericardial thickening and preventing the heart from relaxing. So here you remove the fibrous pericardium as well as that layer of pericardium that's on there, that's almost like a thin film that's holding it in place. That all has to be well removed in order to release the heart. Now, a typical phrenic nerve to phrenic nerve anterior pericardiectomy is what's described here. However, most centers that do a lot of this advocate the completeness of the pericardiectomy, meaning that this area behind the phrenic, diaphragm, so the diaphragmatic surface usually has to be removed, and behind the left phrenic, ideally to be considered complete. And even that term, when we say complete, not really complete, because there's still areas of pericardium that you can't remove that are around the IVC, around behind the LA, and around the large vessels. So you remove, let's say, 90% of the pericardium that you can in order to release as much of it as possible. And we believe that like recurrence of constriction has something to do with the completeness of the pericardiectomy, although I will say it's a point of controversy. Some surgeons and some centers believe that only doing the anterior part could be enough in certain situations. In our center, we favor complete pericardiectomy. Second thing that's controversial is the use of cardiopulmonary bypass. These two subjects have to do together because there's a relevance to it. If you do an anterior pericardiectomy, usually you don't need to go on cardiopulmonary bypass, and you can get away with it and do it that way. However, if you want to do a real complete pericardiectomy and do that diaphragmatic surface and behind the left phrenic, it's very hard to do it, very hard and tedious if you don't go on cardiopulmonary bypass, because every time you move the heart, these are already patients who have very low cardiac output and so on. They keep dropping their pressure when you're not on cardiopulmonary bypass. So you end up doing an incomplete pericardiectomy. So if you want to do this diaphragmatic surface and the back, usually patients go on cardiopulmonary bypass. So in our center, all the anterior part is done off pump. And then once this is completed, the phrenic nerves are identified, they've opened towards the pleural space, and they're going to do the diaphragmatic surface on the back. Patient goes on cardiopulmonary bypass for a short run and then complete the posterior part like this. This is data from the Cleveland Clinic. They're also very strong advocates in completing it this way and of using cardiopulmonary bypass. Here's an image of a calcified pericardium where after resecting the surface, you see the heart bulging through. And here is on the right, the fibrous pericardium being removed. And here, that thin layer that I was describing of restraint that's being removed from the heart surface. Here's a video from our center where pericardiectomy is being performed, removing the fibrous pericardium and that layer at the same time. Slow, tedious work. Here is already gone on cardiopulmonary bypass and is doing a more detailed area there. This is near the end of the surgery. All the surfaces have been released. Heart looks like much more relaxed. CVP had come down. So that's about it for the surgical aspects I want to talk about. The other point that I will say is that in some cases, if the thickened part is going into the myocardium, sometimes they don't have a choice and they have to do this waffle technique and doing kind of like a limited type pericardiectomy. So far in our center, we haven't had to use this. In most cases, we've been able to get away with doing the classical surgery. So what are the predictors of poor prognosis? The presence of other problems. So the post-radiation, why? The post-radiation often has myocardial involvement, they often have valvular disease, they often have coronary disease. A lot of aspects of the heart are also involved. It's not just the pericardium. So their prognosis after surgery is very poor. And there's a lot of details to discuss regarding this as well. And same thing with the post-surgical. Many of them, their EF is not normal at baseline. They have coronary disease or valvular disease. So their risk after surgery is not as good as the patient who has a normal myocardium, normal valves in the idiopathic cases. Okay. What are the predictors of mortality after surgery or of low cardiac output? Radiation, very high creatinine, very bad hyponatremia, older age. These are all indicators of having like a low cardiac output. And also on cardiac catheterization, if you actually have a cardiac index that's very low, that's also an indicator of patient that's probably going to suffer after surgery or might have a little bit of a difficult time. And that was from one of the case series. And from the other case series, they had shown that being on dialysis and higher NYHA class is bad as well. One that hasn't come across these is the ones who have very extensive ascites or the liver starts failing. That's also, you're getting very late. You want to operate these patients before they get to the point where the liver is failing, they have severe ascites, etc. In-hospital mortality is about 6% in patients, and this data from Cleveland. Of the idiopathic, it's very low, whereas the post-radiation is the one that's the highest, is like 27%. And alive at 7 years, okay, 88%, 27%. So 3/4 of the radiation patients are dead at 7 years, whereas the idiopathics are doing much better, okay? Whether or not cardiopulmonary bypass was used didn't affect the survival benefit. Reoperation for bleeding, 4%. And in some cases, ECMO was used due to the low cardiac output syndrome in younger patients. And we can talk about that in the discussion a little bit. Two other points important. If there's TR that's significant, moderate or more, probably you need to do a tricuspid annuloplasty at the time of pericardiectomy, because if you don't do it, you're going to deal with it later because the TR tends to get worse. So about 15% of the patients require a tricuspid annuloplasty if they already have moderate TR when they're going for pericardiectomy. And the ones who have very low cardiac output going in, the utility of ECMO and being vigilant of requiring ECMO in young patients is an important one that we could discuss in more detail as well. So in conclusion, the diagnosis of constrictive pericarditis requires a good workup by echocardiography and the other necessary examinations. The treatment could be medical or surgical depending on if there is ongoing inflammation or if it's mostly scar tissue. Surgical pericardiectomy, usually a complete one is preferred if it's technically feasible, and it usually requires cardiopulmonary bypass in order to do the complete pericardiectomy. And finally, in permanent constrictive pericarditis, earlier surgical intervention is probably better than later in order to do it before the patient has liver failure, etc. And the etiologies are important determinants of the outcome of the pericardiectomy. And this is the slide from our manuscript.
That's fantastic. Thanks, Vartan. I've got a few questions on my end, and if there's any from the audience, just either drop them in the chat or you can chime in as well. But from my perspective, Vartan, I find it difficult to as we all know, the surgery that you very nicely outlined with those beautiful live video clips is not without morbidity. And I find it challenging to judge the timing of when to refer a patient for surgery at an appropriate time. As you mentioned, you don't want to wait too long for things to progress and for there to be end organ damage, but then with the significant morbidity associated with the surgery, you also don't want to do it when they're relatively okay. So how do you kind of reconcile the two sides of patients too well to go for surgery, and then on the other side patients too far advanced to go for surgery?
Without being overly simplistic, I would say some of the indicators that we do use, for example, if they come and sit in your office and the neck veins are very distended and they've already been started on diuretic, or you're thinking of starting diuretic, those are already indicators that you're going towards surgery. Because if you're starting furosemide, or because they have significant edema, etc., and then they come back at follow-up and the edema is better and say, oh, great, furosemide. But that's not the problem. Is that you're dealing with the high intracardiac pressure by giving the furosemide. You're kind of dehydrating them a little bit, but you're dealing with somebody who has a low cardiac output. And those situations are going for surgery. Unless the patient has some other major comorbidity that prevents them from having surgery, that's patients on diuretic or going to be started on diuretic, for me, they're going to surgery. The second key thing is to have a good surgeon that you have collaboration with, that has experience and is always the same person doing the surgery, because there are details of how the surgery is done and they're to prevent like phrenic nerve injury and how to deal with low cardiac output syndrome after. These are important things to prepare and plan when these patients are going to be operated. But definitely earlier surgery is what I advocate. When I receive patients that are very late, if they're young, I still have an opportunity to put them through the surgery and try to get them through with whatever they need, ECMO and stuff like that. But if they present like with ascites, liver failure, and they're older, you're looking at palliation, because you're not going to be able to operate them and get them through a surgery like that if they already have like significant liver failure when they're referred to you. Definitely earlier surgery, I definitely advocate it.
That's great. That's very helpful. Thank you.
Yeah.